Very good morning to all of you. First of all, I want to thank the organizers of Diabetes India to invite me to talk on this very important topic. All technology is all good, but does it match to your pocket? Like it's so we'll just discuss how it goes. So the flow. So this is I have no conflict for this presentation in this conference. The flow of my presentation would be little bit just maybe to touch epidemiology, the challenges which exist currently, what are the various technologies currently available for diabetes management, and cost effectiveness of technology, and then last. So I think all of us know this is no brainer. The whole world, millions and millions of people are becoming diabetes, especially type 2, and again China, India and USA account for almost more than 50% or more than 70% of the whole diabetic population in the world. So that is why, so I think not from a therapeutic angle, we also have to think a lot from education and prevention angle, how we can prevent this a huge burden which is going to affect our next generation. That's very, very important. And if technology can play a role in preventing this huge blast going to happen. Coming to cost, because we are talking about cost effectiveness, exactly we do not have data on India. Now if you see US data, in 2013 they spent somewhere around 548 billion US dollars on diabetes. So that is the global. And 2035 they expect it will be around 630 billion. That is the cost. And if you come to the region, if you see the picture here, this is mainly the government expenditure. So 263 billion from the US government in 2013, from between the years 20 to 79 years of people. And if you see India, it's around 6 billion. So, but that is just again government funding, maybe CGHS and all included. But in India, and all of us know, it's all out of pocket. So the expenditure can be huge, huge and huge. Now these are the challenges for diabetes care. The first table says about overall challenges, the second one mainly patient related, third more of social factors, and the fourth related to we healthcare professionals. So overall if you see the main challenges, rising prevalence of both urban and rural, very high prevalence of pre-diabetes, genetic, not only I think there is significant some environmental factors, because I see a lot of patients now, they are non-obese, no family history of type 2 diabetes, they are very middle class, like I have few patients who are like lassi wala, sabji wala, non-obese, not very bad diet, but still at age of 30, 32, they present at type 2 diabetes. Now, there is some factors apart from genetic, maybe food, agriculture, pesticides or water. We don't know. I think maybe there's no research, I don't know, maybe some research is going on, but we do not know. Apart from genetic, there's something different also which is causing this huge mammoth of diabetes. So that is we do not know. Then delay in diagnosis, all of us know, because people come late and they are not bothered because nothing happens immediately. They are worried for heart attack, but they are not worried for diabetes. Very low awareness, even in educated people. High cost of management, they feel it's a high cost, but they don't realize the complications are much more costly than the management of diabetes in general. And there are a lot of risks, like if you see patient related, poor motivation, economic constraints, denying, stress, nothing happened to me, I'll be fine, let me see that, I will see all that. And for doctors, again, if you see medical training is more focused towards acute care, so chronic care is lacking. Although there are a lot of good centers in India now for diabetes especially. And if you treat more acute diseases, it's more rewarding, both for doctors and nurses. And again, diabetes management needs a team care, which although exists in some of the centers, but not in all the centers. Now, coming to technology. So these are the areas where technology has a role, or currently we have some applications to diagnose diabetes. It can be biochemical, can be microbiological, or whatever. You have now good technologies to detect HbA1c at the clinic, or microalbuminuria, or fasting and PP just at your clinic. Provide initial assessment and treatment, or you can have technology helping you to have ongoing monitoring and management, how it's doing that. And Dr. Malpani spoke, again EHR or EMR will again help you in that, and to screen and detect some of the complications. And definitely this is a big area is on self-management and empowerment. A lot of stuff are coming up and is being coming up in the near future. Now coming to one of the part, glucose monitoring. So all of us know this is the technology for glucometers. I think all of us use, all the patients, although not all the patients, but few patients also use this. Second, you have for delivery you have pens. Again, it's use of technology. We used to have now syringes. Now you have good, sophisticated, good colors, new technology, and other pens. Now for monitoring, apart from glucometers, apart from fasting, PPG and A1C, you have continuous glucose monitoring systems. So you can see glucose variability, you can find out there. Now different in India currently there are only three players which are available in India. One is this one, Medtronic, that is iPro 2. And then recently, just on this forum or a week back, Abbott launched the latest one. I'll show that. And Dexcom, which is present globally, they have entered Indian market through a distributor. All the companies not present. Now this is the latest one. I think this is a disruptive innovation in glucose management. The earlier CGM used to require pricks. Every day you need to have at least 3 pricks, glucometer pricks, to give a feedback or a reference. And the sensor used to cost around 3,500 bucks for 7 days or 6 days, and the whole machine used to cost around 1.5 lakhs for doctors, not for patients. And now in this system, you do not need pricks. It's a factory calibrated, and the sensor you can see here, this small 1 rupee coin is just 1,600 rupees, and this reader is just 4,000 rupees. And it gives you data for 14 days. So you just attach this sensor here and take the reader nearby. It will just read that, and it will capture the data there in different forms. It will give you graph like this. It can give you what is the average. It can also give you how many hypoglycemic events, and it can be transferred to your system, a laptop or a phone or whatever, through a wired, not wireless, wired, offline. Unlike the previous CGM, you need to have an online system. So very handy. And hopefully this will be a good revolution. And if you want to see this system, I think Abbott has a stall there which they can show you a demonstration. So this is a great innovation. Now coming to the other part of technology, that's delivery. Apart from pens, we have insulin pumps, different colors, different type, whatever you need. But unfortunately in India we have only one player. There were 2 players, Roche and Medtronic. I think few months back Roche has withdrawn the business. It's only Medtronic now. So hopefully we should get some more firms like maybe J&J, Animas and other companies come in India. So this is the latest in India now, which was recently approved in US FDA under the category of artificial pancreas called VO, which has a low glucose suspend. Means if you connect the pump along with the sensor, and there is a system in the pump that you can set a threshold. For example, you want to set a threshold of 70 milligram per deciliter. So if the sugars are going to hit 70, half an hour before you will come to know that it will tell you that sugars are going to hit 70. And once it hits 70, patient does not respond, it automatically shuts off, so that the patient does not go into severe hypoglycemia. And again resumes after 2 hours. If patient is still not responding, it again suspends. So unless it comes to normoglycemia. So that's the thing. But there are, again, cost is a barrier. Currently the cost in India of this device is 4.5 lakhs. So again, you need to see both the side who can afford those. There are people who can afford this, and there are people who cannot afford this. So you have to be, apart from clinical indications, you need to see those also. Now this is the latest, which is already approved in Australia, called 640G. This is the first, again in the second category of artificial pancreas. It is going to be launched in India next month, what I got information from the company. So this is a totally, it's like iPhone, colorful, touch screen, and with a predictive LGS. The earlier one was with LGS. This is with predictive LGS. It's like a navigation system. So it will tell you if you set a threshold of 70, and before half an hour it will suspend before it going to reach 70. If you set, so, but there are again challenges how well the sensor and the device talk to each other. So again, if that is 4.5 lakhs, I do not know what price point they're going to launch in India, maybe at least 5 lakhs. And it's not, it's just introduced in Australia and going to be in India next month, called 640G. Again, one of the revolutions for artificial pancreas. Maybe down the line after 3-4 years, we might get a total artificial pancreas, but currently this is the latest with a predictive LGS. Now coming to cost effectiveness of these therapies mainly. If you come to CGM, a lot of studies have shown this study from US, and they have shown that continuous glucose monitoring is cost effective as compared to SMBG only in type 1 diabetes, not in type 2. And again, for India, we do not have data. And again, because the government in US funds this, or the insurance pays for that. That's why they do so many studies. In India, the patient pays from the pocket. So not much of data here, but all of us know the cost of glucometer here and a cost of strip here. This is the data from UK. Again, they have assessed this insulin pumps versus MDI, and they again found out that pumps are again cost effective as compared to multiple daily insulins of 4 pricks only in type 1 diabetes, not in type 2 diabetes as of now, in terms of both A1C and also in preventing hypoglycemia, because you spend a lot of money when patient gets hypoglycemia and goes to a hospital, because in these countries they don't want people to come to hospital because their hospitals are always full. They want to manage them as far as from the hospital. That is why the generation of this remote monitoring, remote management actually started, because they have limited hospital beds. And again, for hospitals, I think all of us know, hospitals are very interested in only the first 3 or 4 days, because they make maximum revenue in those 3-4 days. After that, they are not interested. They are interested for a new patient. So these are all why they need technology, so that they can manage home care. And I think we have a company called Potia, we have recently introduced in India, who does that. Now, this is the latest study, just published in March 2015 from Diabetes Science and Technology. It says, in short-term studies, artificial pancreas systems, that is what I have shown you, both hypoglycemia rates and reduce both hypoglycemia and plasma glucose. Both pumps and real-time CGM are cost-effective technologies, but and again in type 1, but their wide adoption is limited by cost, psychosocial and educational factors. So we need to be mindful whenever you are recommending a patient for pump. Not only cost, he has to be motivated enough to use that. Otherwise, it can be detrimental. Now, these are some of the recommendations of insulin pumps endorsed by both ADA and ESD. Pumps should be considered for individuals with diabetes who have these conditions, especially recurrent severe hypoglycemia, wide fluctuations, microvascular and microvascular complications, good metabolic control, but insulin regimen is not compromised, is compromising lifestyle. Other indications can be young children, especially infants and neonates, who actually benefit a lot from pumps because they are in the growing stage. Adolescents with eating disorders, children with needle phobia, and other people who have a very rough lifestyle like athletes or sportsmen. A good example is Wasim Akram. Although he does not use pump, but profile like him would always get benefit from pump, because you have flexibility of using pump in different, like you can have a customized basal, you can have a customized bolus. And now the other area is ICT, information and communication technology. Under this, you have self-care, you have M-health, you have telehealth, you have remote monitoring. Whatever you talk, everything comes under this banner of information and communication technology, IT enabled. So you have so much of stuff going on in the world on this. But the prime question, whenever you get a technology, we have to first ask 4 things. Is the technology sound? Was the program effective? Is it cost effective? And is it practical? Just don't adopt it. Please evaluate it properly. So you can weigh it in terms of practice change, substitution, spread, or on the other side, cost efficiency and other stuff. So you can have a maybe 2x2 chart and make it where exactly the technology you are trying, it fits. The best one would be here in this angle, if it is more effective and less costly. So this is NICE. We do not have any guideline in India. NICE says if any treatment costs more than 20,000 or 30,000 per quality, that is quality adjusted life year, it is not cost effective. They say particularly. So they do not introduce this in UK at all. If the cost of treatment is, or the cost effectiveness is not there, they do not. I think I have only one slide. So anyway, so I had only my last slide, that technology has to be effective. Not only effective, it has to be very, very cost effective, so that we can take the diabetes management to the next level. Otherwise, I feel technology sometimes can hinder our way we manage diabetes and patient empowerment. Thanks for a patient hearing.